This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon, and we are coming to you today to discuss a topic that sits at the intersection of complex pediatric management and perioperative care.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from PLOS ONE, published in 2026, titled Fascia Iliaca Compartment Block for Surgical Analgesia in Children with Osteogenesis Imperfecta, a retrospective cohort study.
Now, Ilara, I can already hear some of our residents asking, why are we discussing a regional anesthesia block for orthopedic procedures on a neurosurgery podcast? But as we know, when we are dealing with osteogenesis imperfecta, or OI, we are often managing patients with significant spinal deformities, basilar invagination, or craniocervical instability. The perioperative management of these children is a multidisciplinary marathon.
Exactly, Dr. Aris. The paper highlights that children with OI present a unique challenge. Because of the underlying collagen mutations, they have extreme bone fragility and often undergo multiple corrective surgeries. This study specifically looked at the Fascia Iliaca compartment block, or FICB, as a method for surgical analgesia. For our listeners who may need a refresher, the FICB is a regional technique that targets the femoral, lateral femoral cutaneous, and sometimes the obturator nerves by injecting local anesthetic into the potential space between the fascia iliaca and the iliacus muscle.
Right. And in the context of OI, traditional systemic analgesia is a double-edged sword. These children often have respiratory vulnerabilities or altered drug metabolism. If we can provide localized, high-quality surgical analgesia without the heavy reliance on systemic opioids, we change the entire recovery trajectory. Ilara, let's dive into the methodology of this study. It's a retrospective cohort study. What were the authors looking for?
The authors were evaluating the efficacy and safety of FICB in this specific pediatric population. Because it was a retrospective cohort, they looked back at cases over a multi-year period to compare patients who received the block versus those who received standard systemic analgesia. The primary goal was to see if the FICB provided superior or equivalent surgical analgesia while potentially reducing the opioid burden.
The retrospective nature is important here. OI is a rare condition, a rare bone disease, so a prospective randomized controlled trial is incredibly difficult to power. A cohort study allows us to see how these blocks perform in the real world of a busy surgical center. What did the paper say about the anatomical considerations for these children?
That's a key point the paper stresses. In children with OI, the anatomy isn't always textbook. They often have significant scoliosis, pelvic tilts, or previous surgical scars that can distort traditional landmarks. The study notes that the fascia iliaca compartment is a reliable target because it's a large potential space. By using the fascia as a landmark, the anesthetic can spread to the three major nerves of the lumbar plexus that we mentioned. For a neurosurgeon, this is similar to how we think about the epidural space. It's about finding that correct plane to allow for the volume-based spread of the medication.
And in neurosurgery, we are increasingly looking at regional blocks for our spine cases, erector spinae blocks, for instance. But specifically for the OI population, who might be coming to us for a complex tethered cord release or a posterior spinal fusion, why is the FICB mentioned here?
Well, many of these children undergo concurrent procedures, or they have significant hip and femur pain that complicates their postoperative mobilization. The paper argues that surgical analgesia shouldn't just be about the 60 minutes on the table, but about the first 24 to 48 hours. If the patient is in a neurosurgical ICU after a major cranial or spinal intervention, but they are also recovering from orthopedic stabilization, the FICB provides a quiet limb. This prevents the physiological stress response, tachycardia and hypertension, which we desperately want to avoid in a patient with a fresh dural repair or a fragile intracranial pressure balance.
Let's talk about the results mentioned in the study. When they looked at these surgical analgesia scores, what was the takeaway?
The cohort that received the FICB showed significantly lower pain scores in the immediate postoperative period, but the most compelling data point from the study was the reduction in rescue analgesia. In the non-block group, the frequency of breakthrough pain requiring intravenous opioid was much higher. In the OI population, opioids are particularly risky because of the potential for respiratory depression in patients who may already have restrictive lung disease from kyphoscoliosis.
It's a multimodal approach. We use the term opioid sparing, but for these children, it's almost opioid essential to avoid them where possible. Did the study mention any complications related to the block? With OI, I'd be worried about hematoma formation or nerve injury.
That's where the retrospective cohort study design gives us some peace of mind. The authors reported a very low incidence of complications. Because the FICB is a distal block, meaning you aren't getting as close to the neuraxis as you would with a caudal or epidural, the risk of a catastrophic hematoma that could compress the cord is virtually non-existent. They did mention the importance of ultrasound guidance, which has become the standard of care to ensure the needle doesn't traumatize the fragile bone or the vascular structures.
It's interesting to think about the fascia iliaca itself in these patients. If the collagen is defective, does the fascia provide the same pop or resistance that an anesthesiologist expects during a landmark-based block?
The paper actually touches on that. They suggest that because of the connective tissue issues in OI, the tactile feedback can be unreliable. This reinforces why the study advocates for imaging guidance techniques. We can't rely on the feel of the fascia in a child whose fascia might be thinner or more compliant than a healthy peer.
Let's bring this back to the neurosurgical suite. When we have a patient with OI on the table for, let's say, a cervical medullary decompression due to basilar invagination, we are focused on the brainstem and the upper cord, but we often harvest bone graft from the iliac crest.
Precisely, Dr. Aris. This study's focus on surgical analgesia for the iliac region is directly applicable there. If we perform an FICB, we can potentially mitigate the donor site pain from an iliac crest bone graft harvest. We often forget that the graft site can sometimes be more painful for the child than the primary neurosurgical site.
That's a great clinical pearl. We focus so much on the neuro part that we forget the ortho part of our own procedures. Now, as a research fellow, Ilara, what are the limitations of this study that our listeners should keep in mind?
As with any retrospective cohort study, there is an inherent selection bias. We don't know exactly why one surgeon chose a block while another chose systemic meds. Perhaps the healthier patients got the blocks or vice versa. Also, the study doesn't look at long-term outcomes like the development of chronic pain or the impact on bone healing, which is a major concern in OI.
True, but it moves the needle. It tells us that in the children with osteogenesis imperfecta population, we have a safe, effective tool for surgical analgesia. It encourages us to look beyond the standard and tailor our anesthetic plan to the specific fragility of the patient.
And it highlights the fascia iliaca compartment as a viable target even in complex genetic syndromes. The study concludes that the FICB should be considered a cornerstone of the analgesic plan for these patients to facilitate a smoother recovery.
Well, this has been a great dive into a specialized but highly relevant area. It's a reminder that as neurosurgeons, we aren't operating in a vacuum. We are operating on a whole patient, one who might have brittle bones and a complex pain profile.
Exactly. The paper, Fascia Iliaca Compartment Block for Surgical Analgesia in Children with Osteogenesis Imperfecta, is a must-read for anyone involved in the perioperative care of these brittle bone patients.
Thank you, Ilara. And to our listeners, remember, the best surgery is only as good as the recovery that follows it. Join us next time on the Neurosurgery Hub podcast.
See you then.